Hello and welcome to the Under Pressure podcast. I'm Dr. Jonathan Sakia and I'm proud to be your host. We have a fascinating guest today, Yasser Bouklouche, who can be perfectly described as a kind of Swiss Army knife of biomedical research and quantitative analysis, a data science guru who has a focus in biostatistics, surgical outcomes, and cost reduction. And our topic today is Decoding Trauma Care, a data scientist journey in surgery and compartment syndrome insights. And I'm looking forward to diving in. But let me give you a little bit of background. And first of all, an important notice that this podcast has been supported by Myo1, a Canadian medical device manufacturer. And please refer to the show notes for further information. You can be in touch with us at underpressure@nextsense.com. That's underpressure@nxtsens.com to ask any questions that we shall endeavour to answer. If you want to give us hints for other topics you'd like us to cover. So, background. Yasser obtained a doctorate in pharmacy from the University of Oran 1 Ahmed Ben Allah in Western Algeria, a master's in public health from Aix-Marseille University focused on epidemiology and biostatistics, a baccalaureate degree from the University of Montreal, and he's now studying for his doctorate in medicine from McGill University, also in Montreal, which I think is one of the world's most beautiful and intriguing cities. He has experience in pharmaceutical supply chain management for Médecins Sans Frontières, Doctors Without Borders, and Save the Children International, as well as managing medical supplies in Sudan, the Democratic Republic of the Congo, and Nigeria, among others. And he's worked in medical communications and served as an officer in the Algerian military. He's also worked as a clinical researcher and data scientist and lecturer in biostatistics in Montreal on various projects, and he's been working with NextSense for their Compartment syndrome project for nearly 2 years. Yasser tells me he's very interested in mouse and human genomics with hands-on experience with epigenomics projects, and he said, "Give me a keyboard and let me run the numbers." Yasser speaks Arabic and French as well as English. You know, my dad had a great expression for his monolingual son. Anyone who speaks English with an accent, Jonathan, speaks one more language than you do. Yasser has a number of publications, and having worked with him on this project, I know him to be a kind, calm, wise, and gentle chap. So, without further ado, welcome, Yasser Bouklouche.
Good morning, Jonathan. Thank you for having me.
You're welcome. It's a delight to chat about these things with you. So, as I mentioned in my introduction, you were initially trained as a pharmacist in Algeria and then obtained an epidemiology and biostatistics, it's easy for me to say, biostatistics master in France. And you worked for Doctors Without Borders for many years and other charities, as I mentioned. How did these experiences impact the man you are and your perspectives on healthcare and trauma care?
Well, I would say for the last 15 years, one of the things that I experienced that's really interesting is moving from Africa to Europe to North America is sort of moving through time while moving through space. Because I was trained in a low-income, low-resource country where the most focus was actually put on very basic needs. And then I moved to more developed places and with higher resources where the focus is a little bit put on other things. For instance, where I grew up, the focus was mostly on maternal health, maternal mortality, child mortality, under-5 mortality. And there was very little actually being done in terms of oncology or any complicated surgery or palliative care, because those fields usually drain a lot of resources in hospitals. And when I moved to Europe and worked in North America, one of the things that I noticed is how that the availability of resources actually allow you to do even more things. So basically, it's like moving through the last 60 years within just a time frame of 15 years. So moving, I say to my friends, I've moved through time by moving through space.
That's a very, very interesting perspective. And yes, I've had the probably the biggest privilege of my life is traveling to different countries, to so-called lesser developed countries. And I think I would say that the things I learned were more profound and more numerous than the things I taught. Going to countries that didn't have the resources we have in the so-called more developed countries, the West, but how they managed to make do with much less. But also, more importantly, given that we work in health care, the kindness that you see, the humanity that you see, is sometimes really illuminating. And maybe one day you can write your memoirs about all these, but I think you've got a bit more work to do yet.
Yeah.
So, what motivated your transition from biostatistics to pursuing medical school at McGill, where you now are? And what inspired you to pursue a career in medicine, frankly? You seem to have a thirst for knowledge and you have more degrees than I've had hot dinners.
Yeah. It was so the move to biostatistics or pharmaceutical biostatistics was more of a natural thing. I moved to Europe. I was good with numbers, and I thought, well, okay, what kind of master's degree? I do. I was pretty bored. Wanted to do something new, so I moved into biostatistics. Um, but the move to medicine was something that was mostly motivated by my experience volunteering in the African continent. Um, uh, I spent pretty much 5 to 6 years volunteering with different organizations, mostly Doctors Without Borders, but also Children or the Mentor Initiative. Um, and during those missions, I was in charge mostly as a pharmacist. I was in charge of logistics, and so I was basically in charge of um, buying medical supplies in a place, transporting it, and making sure it arrives actually to a designated facility. And while doing that job, I had the opportunity to basically meet volunteers, doctors, physicians, surgeons coming from all around the world. And I remember the first C-section I saw was in a remote hospital in southern Sudan on the border with North Sudan, and it was quite a fascinating case. And I had the chance to attend and with an Australian surgeon, and I looked at the surgery. It was a fascinating thing. So over the years, actually working in hospitals and working in an organization like Doctors Without Borders, one can naturally imagine how that affects the aspirations and the motivations of an individual.
So, can you see where your journey at McGill might take you? What? Let's look a few years into the future. What's your aspiration beyond this?
I would say that I've been actually quite invested in trauma care for the last 4 years, and when I work in the private sector, also we're heavily involved in trauma care. Um, I see I have a very keen interest in it. Obviously, like there's more time in the future to reflect more upon it. But trauma care is definitely something that really interests me because I have invested a lot of time and energy doing research in that field.
Excellent. Well, we'll come back to trauma, but I'd like to dig a little bit deeper into your background. You're a data scientist in both the academic and commercial sectors. How do you see the intersection of data, academia, commerce, technology, research, and surgical practice evolving in the future, especially in an environment, certainly in the United States, that seems to view interactions between academia and the commercial sector with a jaundiced eye, shall we say?
That's a very good question. So, what I studied biostatistics in France, intersection between the private sector and academia was rather scarce. But in North America, it was quite surprising to see a very good bridge actually between the two. Um, how I see it is that technology has already had a profound effect on medical practice in general, and one of the things that we see like through the implementation of electronic medical records, is the possibility now to pull data at a very large scale and have access to that data to do research, whether for academic purposes or even for private or business purposes. So the advancement there has been quite immense. Now, and for me personally, as a data scientist, the revolution now is more on the AI side, and what we see now is private businesses investing heavily in developing either large language models, GPT type models to answer specifically research or medical questions. Um, but also, we see other models actually being developed as assistant to a sort of PAs, basically physical assistants. So they would assist the physicians in the practice, and this is where the intersection between the academics, the guys who actually build the models, the mathematicians, the technology companies who invest in those technologies, and then how those affect the medical practice and even actually the patient's outcomes. Because ultimately, these AI tools are going to improve the patient management, the follow-ups, and ultimately the clinical outcomes.
So you've mentioned AI. We hear about data science, machine learning, algorithms, statistics, and AI a lot these days. What's Yasser Baklush's take on all of this? How can data science improve surgical care? I think I've got some thoughts about how it can, but I want to hear from someone who actually knows. And the dystopian things we hear, about the terrible things that are going to happen with AI. Should we be concerned?
Um, I think for the time being, the implementation is not strong enough to be concerned, but we can come to that later on. The way I see it is, it's a very good thing that statistics have been a lot have been used in medical care for quite a long time to evaluate the efficiency and performance of procedures. Uh, More recently, we see machine learning and AI being used more to improve precision and accuracy during procedures. Um, but those are still at a very baby step level. So the implementation is rather limited to large centers, big trauma centers that have the resources to deploy those technologies. But also, the technologies are not mature enough to get democratized. Uh, so going to the average clinic here in Montreal or in New York or in LA, you're not going to see the average arthroplasty being done with AI assisted robotics. So these are very much limited now to research facilities and facilities that can afford to invest heavily in these technologies, because the costs incurred by the development of these technologies is rather high in the very beginning, and so it's not profitable yet to deploy them at a large scale. So and this is one of the limitations that we are seeing. Also, there are certain limitations as to the efficiency and performance. Obviously, you, Jonathan, as a surgeon, you know this. Surgery requires a certain level of finesse, and one of the limitations we see with robotics, with AI-assisted robotics right now, is that it lacks that finesse, and there is anatomical differences between patients that AI has a lot of trouble dealing with, and that's why we see certain limitations. So I would say overall. Data science is going to play a role. It's already playing a major role in that, in improving computer vision, in improving robotic mobility and finesse. But still, it actually hits the wall with especially with trauma, because trauma cases are so different from one another. Like if no two fractures are equal, so the cases are very, very different. You will never have the same angle of fracture between two patients. You will never have the same type of arthritis location between two patients. Um, and this is where AI has to have or to develop this capacity to adapt as a human would adapt to the differences between patients. And this is where AI is struggling a little bit right now.
And the dystopian element of it?
The dystopian element of it, unfortunately, we already see it. It's more on the financial side of things. So billing is already almost managed by AI for large hospitals. So there you have AI-assisted scribing, charting, but unfortunately also you have AI-assisted review of claims, of insurance claims. We have heard recently of the first large insurance company in the US that has automated denials using AI. And this actually causes certain ethical concerns there. Should an AI actually make the decision that could affect the life of a human being? So I would say this is where probably the ethics come into play. Um, but there is a lot of effort uh, uh, into basically working on a legal framework. So right now it's we're in a sort of Western type of a sort of really Wild West type of AI field. There is almost no regulation. It's a free for all basically environment. Um, so people are just using AI and all sorts of things, but we don't see any regulation implemented yet. And I believe that in the future, probably there will be some form of legal framework to work with um, that's specific for medical care because we're humans after all, and we care about the healthcare we give our people. And so probably there will be some legal framework to work with. But so far, we haven't seen any legal framework specific for healthcare.
Yeah, thank you for that observation. I mean, normally people sort of default to talking about the, robot warriors taking over the world. It can be a simple matter as someone having their care denied, heaven forbid. I mean, I know the denial process when I was practicing in the United States drove me
Yeah.
up the wall at the despair and dis-ease it caused to patients who had to wait and jump through yet more hoops to get the treatment that a caring physician or other practitioner had prescribed for them. So yeah,
Mhm.
well, good
Yeah.
point, yes. You
Yeah.
recently moved to Montreal, as I say, one of my favorite cities, where you got deeply involved in trauma care research. Tell us more about it. How did your background in biostatistics sort of influence your approach to understanding trauma data?
Okay. So I moved here about like 7, 8 years ago, and when I arrived
That's
here, I
recent,
yeah, relatively.
relatively recent. It's all a
Uh,
matter of percentages.
and one of the obstacles actually when you move to North America, obviously with an African degree, is I couldn't practice as pharmacist here. So and I wasn't really interested either. I like doing logistics for Doctors Without Borders, but I don't necessarily like the pharmacy type of job, just sitting behind a counter. It was not something that was for me. Uh, so basically, I told myself I'm good with numbers. I love crunching numbers, and I had a keen interest in IT. So I looked at something that could be done there, and this is where I got really involved in bioinformatics. So bioinformatics is a sort of field that's between basically software engineering and biology, and specifically genetics. So what I worked on is epigenetics mostly, and we did a couple of projects there, probably more than a couple of projects that dealt with epigenetics, and I acquired actually quite a unique set of skills there because bioinformatics deals with large databases because human genome is really big, and so we were analyzing human and mouse genomes. And this was a tremendous experience because it exposed me to dealing with those really large databases. And from there, acquiring that skill, it was really easy to jump into trauma care. So I was looking just to change jobs, and I met Dr. Harvey at McGill, who is on your show probably recently, and and basically we started working on analyzing large databases, leveraging those large databases, using like very specific approaches that weren't used in the past.
So
So
Ed,
that's how I ended up in.
yeah, so Ed Harvey, for the benefit of folks listening in, is professor of orthopedics at McGill, and a brilliant and very innovative and also a very nice chap.
Yeah.
So, follow-on question for you, Yasser. How does data science improve the knowledge and understanding we have of severe extremity trauma, and more specifically, compartment syndrome? So, again, compartment syndrome occurs where you've got limitation of space in like a limb, for instance, the lower limb with the tibial fracture. You get swelling, and the swelling compromises the blood supply of the muscles, which may then become compromised and may die and can even lead to a fatality, but certainly considerable morbidity. So, talk to us a little bit about your perspective.
So compartment syndrome is really something that I would characterize as a rare complication. So it's less than 3% of people will develop it after a fracture. And this makes it really uniquely challenging to study. Because in general, we would run either clinical trials or we would run retrospective studies, and then we would look at a certain number of cases. But when the complication rate is this low, it becomes really very challenging to study, and this is where uh, analyzing large databases has come into play. So we had to collect large amount of data in order to have enough cases to study those. Um, what we did was basically get access to those large databases and try to leverage them to understand better lower extremity trauma. So we focused mostly on tibial and fibular fractures, so with a complication for compartment syndrome. Where data science actually comes into play is that you can't really use the old statistical methods that we used to use back in the days. So it had so the techniques that we started using were quite novel because the databases were so large that they wouldn't fit actually in a single computer. So the techniques and the programming techniques and the approaches for analysis are quite unique, and this is where data science actually comes into play. We also didn't use traditional models that would be used in medical science to explain the effect of uh, factor A or factor B or factor C on the outcome. We used machine learning approaches so algorithms that are completely different um, to actually discover or uncover certain factors that might actually predict uh, the development of ACS or acute compartment syndrome in a patient. So that's really how we approached it.
So we'll dig into that. What specific data, so say machine learning algorithm, what specific data did you leverage to gain the insights into compartment syndrome that have clinical relevance to clinical practitioners, folks at the sharp pointy
Yeah.
end?
So we leverage multiple databases, but the most important one was the Trauma Care Improvement Program database that's actually
TQIP.
curated by the TQIP database. They sometimes it's called also the National Trauma Data Bank, and it's curated by the American College of Surgeons. It's a data bank that's really large. It encompasses about 6 to 7 million trauma cases. And it was quite interesting to see that very few scientists actually had used it to do research, and it's a very high quality data bank, and it allows us also um, to study very rare conditions like compartment syndrome. So TQIP was the main data bank that we used for that. Absolutely.
Absolutely, and point well made. These things were set up not just to gather data and do nothing with it, but actually to correspond with it, to talk to it, and say, okay, what can you teach me? So
Yeah.
that's excellent. What
It's
I'm
yeah.
sorry, go
It's
ahead.
Yeah. So this is one of the things that we see nowadays in medical care is that we're collecting so much data through, like, if you go to your doctor now, chances are they're using an electronic medical record system. So the data that is collected is humongous. And one of the things that we see is that leveraging that data, or the amount of people that are working on that data, is rather scarce. So it's a very small number of people working on that data, and the amount of data that's available is just huge. What we are actually noticing is that a lot of our statisticians are lacking the skills to work with large databases, because those usually are database types that are used in business, and this is why our traditional academic statisticians are having trouble with that. That's one of the gaps that actually we exploited to get an advantage over other researchers in compartment syndrome.
Yeah, yeah. So, what were the knowledge gaps that you've seen around compartment syndrome, and how did you and your team contribute to improve our understanding of ACS?
That's a very, very interesting question. So, compartment syndrome has been studied for the last 60 to 70 years. The one of the things that we noticed is that there was very little data or models that would actually replicate compartment syndrome in an animal, for instance. So, one of the projects that we did was that we tried to replicate, or we created a model for compartment syndrome. So we used pig models to replicate compartment syndrome, and try to understand the mechanistic behind it. So the pathophysiology of how does the onset of compartment syndrome actually works. But we also used a data analysis driven understanding of acute compartment syndrome. And that refers to the work we did using big data. One of the things that we did, for instance, is that we tried to find unique combinations of compartment syndrome with certain problems, with certain medical problems that would actually help us understand. For instance, we studied the emergence of compartment syndrome in patients who are hypertensive. And what we noticed was that hypertensive patients don't develop compartment syndrome at the same rate as the normal population. They tended to develop compartment syndrome at a much lower rate, which actually led us to hypothesize that there is something that has to do with the differential pressure, the perfusion pressure of the muscle tissue, and this was also a supporting evidence that probably the driving mechanism of compartment syndrome was the perfusion pressure. Furthermore, we looked at patients who had cirrhosis because we wanted to understand whether oncotic pressure had an effect. So we looked at a combination of compartment syndrome and cirrhosis, and this is where big data again actually allows you to do that, because over 6 million patients were reviewed, and we had only 16 patients with a combination of cirrhosis and compartment syndrome, because both conditions are extremely rare. And so the combination of the two is even more rare. So, so this is one of the things that we did. And by looking at cirrhosis cases, we saw that almost systematically they would develop compartment syndrome upon having a fracture. And this led us to hypothesize that there is the combination of pressure. So not only the static pressure uh, uh, that is in the vessels, but also the oncotic pressure of the liquid itself is involved in the perfusion of the muscle, and could explain the onset of compartment syndrome. Because patients with cirrhosis who have very low oncotic pressure because they lost all the albumin production, those patients didn't develop compartment syndrome. They did develop compartment syndrome almost systematically. Um, and that gives you an idea about our approach. So you have to find these combinations of very rare cases that affect a certain factor, and that could help you explain the pathophysiology behind the phenomena of compartment syndrome. And then we hope to do even more models in the future, animal models, but also do big data on those models.
I must
Try.
admit, the stuff that you previously told me about and that I learned from you and from Ed, and you see the power of the data that's driving those observations, it's pretty damn convincing.
Yeah,
And when you hear it, you go, okay, yeah, well, that makes perfect sense. For
yeah,
instance, well, is the patient hypertensive? Because tissue perfusion pressure matters, right?
yeah,
So yeah,
absolutely.
good on you.
Yeah,
Well, this is an uncomfortable question, but money is not an inexhaustible resource, and a lot of focus on cost reduction these days. You've worked on those angles, right? How can we improve the cost of or reduce the cost of trauma care? What does your work show, more specifically in terms of compartment syndrome? Yes.
so, in terms of costs, we so this is where I have also to disclose my conflict of interest as also an employee at Nexus Microsystem. We did a lot of cost analysis studies, and what we noticed was two things. First of all, patients received actually treatment for an hypothetical or suspicion of uh, acute compartment syndrome. And that was done under the name of a prophylactic fasciotomy. So prophylactic fasciotomies are these really, really gruesome procedures that are done where we open the muscle longitudinally and we release the pressure in order to save the muscle. Sometimes there is such a high suspicion of compartment syndrome that the surgeons would actually rush to the OR and do it. However, those procedures come at a very high cost. So not only high cost for the hospital or for you, for instance, you're in the UK for the NHS, it's going to be a cost in terms of like length of stay and resources being used, but also cost to the patient if the diagnosis is wrong and the procedure is done prophylactically. Well, then the patient is going to suffer the consequences of that procedure because it's not a let's say very tiny incision. It's quite a long incision that's left open for a few days, and it actually can lead to an increased risk of infection and complications, even in patients that didn't necessarily develop compartment syndrome. And so, what we thought of is how can we actually affect that, and this is where Maya One actually worked to develop this device that allows for continuous pressure monitoring and can allow for a better specificity. And specificity reduces for us the number of prophylactic cases, or what we call false positives in statistics. And by reducing those, we reduce dramatically the caseloads for the surgical departments. We reduce the length of stay for the hospital because those patients are not receiving those procedures. So they get discharged earlier. But also for the patients actually don't receive an prophylactic procedure, and therefore they can have much better clinical outcomes. We by reducing also the number of unnecessary fasciotomies, we're reducing the risk of infection, non-union, a risk of long-term morbidity, and those are additional costs for a healthcare system. So this is where we have shown that in internal compartment syndrome specifically, uh, it's not so much the detection because at some point compartment syndrome is so full blown that a surgeon is not going to miss it. But it's actually those really suspicious cases that might receive a prophylactic fasciotomy. If we were to reduce them, well, then we would save a lot of costs to the healthcare system.
Yeah, it's not a minor operation. If you have a complication after an operation that was life saving, a wound infection after doing a colectomy for pseudomembranous colitis in my world is, you never like morbidity as a surgeon, but you can say, yeah, well, I saved the patient's life. But to have a complication, a non-healing wound, a need for skin grafts, 16 days of hospitalization, getting a hospital-acquired infection, whatever it may be, for an operation that one didn't need, then that should give us all
Yeah,
pause for thought.
yeah.
So I want to come back sort of full circle and talk about YASA with my final question. You've hinted that your future lies in trauma care and surgery, maybe as a trauma surgeon, as critical care doctor, whatever. Do you have any aspirations that you'd care to share?
Uh, I'm certainly going to continue using data in the future. It's something that I really love. I love doing analysis. I love coding. It's something that am really very attracted to. So probably I'll get more involved in data-driven solutions, but also I want to get involved in probably AI-assisted robotics, uh, minimally invasive surgery, or surgery assisted with AI in multiple ways. I think by the time I actually finish my residency, AI will be probably everywhere in hospitals, and even certain specialties now are suffering from the AI driven solutions. Probably primary care will be completely assisted by AI. And so this is why my focus is really on leveraging my skill sets to get as much for the patients as possible. And I think in trauma there is a gap that hasn't been filled yet. So one of the things that's primarily actually interesting to me is AI assisted prosthetic limbs. So prosthetics now are mostly static. We see a little bit of bionic appearing here and there, but we see now also bionic limbs with AI assisted motor control, with sensory feedbacks, and touch. So basically, touch sensitivity, and they feed it back to the patient. And those solutions are still in development, and those are really, really exciting. Not only for me as a researcher, but also for the patients. And that's probably what I see myself going forward.
Well, everyone talks about artificial intelligence. It's really nice if there's real intelligence, and it's lovely talking to someone who possesses it in abundance. So it just remains for me to thank you, Yasser Bakluj, for being with us today, for sharing your work, and for all you've done and will continue to do for the patients that we all exist to serve. Thank you, Yasser.
Thank you so much, Jonathan.
So, to the audience, thanks so much for taking part of in this podcast, for taking time out of your busy day to listen and demonstrate a desire to see the best care for your patients. Please share this with your colleagues, post on social media so more people learn about it, and write to us with comments, questions, or suggestions for other podcasts at underpressure@nextsense.com. Underpressure at nxtsens.com. We'll put that in the show notes. And you'll also see there Yasser's conflict of interest disclosure. Thanks also to My01 for supporting this podcast. And all that remains for me to do, as your host, I'm Dr. Jonathan Sakya, is to say thank you for joining. Please stay safe, stay well, stay curious.